Welcome back to Decode Healthcare. I'm your host, Harshal, and today we're diving straight into the brand new CPT 2026 Telemedicine Code Block. As your resident medical coding instructor, I am beyond thrilled to bring you part 17 of our massive explainer series on the updated guidelines. Guys, we are finally moving away from the old, clunky ways of slapping modifiers onto standard office visits. We're stepping into a completely new era of dedicated telehealth codes. So, if you've been pulling your hair out over outdated telehealth rules, that post-public health emergency confusion, or just trying to figure out if you should use a standard office visit code or something else entirely, well, this explainer is absolutely your ultimate solution. Today, we're going to unpack the brand new categorical decision tree the AMA just dropped for 2026. The goal? To help you stop second-guessing your billing and literally guarantee your documentation is audit-proof. Here's how we're going to break it all down today. First, we'll look at the overarching 2026 framework, then jump into audio-video visits, followed by audio-only visits. After that, we'll cover brief check-ins and finally wrap up with those tricky guidelines and edge cases. All right, let's kick things off with Section 1, the 2026 Telemedicine Framework, which introduces a dedicated code category for synchronous encounters. Looking directly at the new guidelines, you'll see we now have this dedicated block right here, codes 9800 through 9816. Historically, you know the drill. You take a standard 99202 through 99215 office visit, slap a modifier on it, and call it a telehealth encounter. Well, not anymore. The CPT editorial panel completely revamped this. They established these entirely new codes to be used instead of in-person visits whenever it's medically appropriate. And keep in mind, they are explicitly designed for synchronous, real-time, interactive encounters. Moving right along to Section 2, let's talk about synchronous audio-video visits. These are your real-time, interactive encounters covering codes 9800 through 9807. Now, this matrix right here is honestly perfectly structured. You can select these codes based on either medical decision-making, your MDM, or the total time spent on the date of the encounter. Here's how it flows. For new patients, your base code is 98000, starting at 15 minutes, and then it steps up in neat 15-minute increments all the way to 98003 at 60 minutes for high MDM. Meanwhile, for your established patients, you start at 98004 for 10 minutes, and that steps up in 10-minute increments, capping out at 98007 for 40 minutes. So, what's the big takeaway here? It's absolutely that baseline time distinction. When your providers are doing time-based billing for video visits, a new patient requires a full 15 minutes just to meet that straightforward threshold for 98,000. But an established patient, they only need 10 minutes to hit their threshold for 98,004. So, golden rule here, always check that patient status first before you even start looking at the clock. All right, let's pivot to Section 3, synchronous audio-only visits. These are your telephone care guidelines, spanning codes 9808 through 9815. Now listen closely to this part, because I guarantee this is exactly where audits are going to happen. If you're billing those audio-only codes, 98008 through 98015, the actual medical discussion absolutely must exceed the 10-minute mark. The CPT guidelines are super strict about this. And notice, it's based entirely on the time of medical discussion, not your MDM. So if your provider is chatting on the phone for, say, 8 minutes, no way. That doesn't even qualify for this code block. It has to cross that 10-minute finish line. If you're looking closely, you'll probably notice how these time thresholds completely mirror the audio-video codes we just looked at. It's the same pattern. For new patients on the phone, codes 98008 to 98011 perfectly mirror those 15, 30, 45, and 60-minute marks. And for established patients, 98012 through 98015 hit the 10, 20, 30, and 40-minute marks. But here is the kicker. You do not count the time your staff spends establishing the connection or arranging the appointment. It is strictly 100% the time spent in medical discussion. Moving down our list to Section 4, brief virtual check-ins. This focuses on patient-initiated brief triage, specifically code 98016. Okay, so wait a second. I just told you that you need more than 10 minutes to bill the standard audio-only codes, right? So what happens if the call is just a super quick 5 to 7 minute triage discussion? Well, that's where code 98016 comes in to save the day. It's your go-to for those short little touch points. It is specifically a 5 to 10 minute service initiated by an established patient, and it's really just designed to figure out if they actually need a broader full exam. You don't even need video technology for this one, so a quick phone call works perfectly. Just keep in mind, if the medical discussion is under 5 minutes, you just don't report it. Because this is a triage code. The AMA put a really strict timeline rule around 98016. Think of it like a sandwich. The check-in cannot stem from a previous evaluation and management visit that happened in the past 7 days. On the flip side, if this quick check-in actually leads to an EM visit within the next 24 hours, or even at the very next available appointment, you don't bill the 98016 at all. Instead, that brief triage time just gets bundled right into the total time of that subsequent in-person or full telemedicine visit. All right, we've made it to our final part today, Section 5, Guidelines and Edge Cases, where we solve those real-world coding dilemmas that we all run into. This is a classic everyday dilemma. I want you to imagine your provider is 20 minutes deep into a great synchronous audio-video consult with an established patient. Everything's going fine, and then boom, the Wi-Fi completely drops. The video disconnects, and the provider has to scramble to finish the last 15 minutes of the encounter on a standard audio-only phone call. We've all been there, right? So how do you actually bill that mixed encounter compliantly? Thankfully, the 2026 guidelines give us a very clear golden rule for these annoying disconnects. You report the service that accounted for the majority of the time during the interactive portion. So in our little scenario, 20 minutes were on video and 15 were on audio. Because video was the majority of the time, you'd confidently bill from the audio-video block. Pretty straightforward. But if the breakdown was flipped, say 5 minutes of video before dropping to 20 minutes of audio, you would switch gears and bill the audio-only code as long as that total audio discussion still cleared that 10-minute hurdle. Now, let's quickly touch on the administrative side of the claim. Because even though we have these fancy new dedicated codes, you still have to append the correct modifiers and place of service indicators. You're going to use modifier 95 for synchronous audio-video and modifier 93 for audio only. As for your place of service, your POS, you use POS 10 if the patient is physically located in their home during the visit. But if they are literally anywhere else, at work, in a hotel room, sitting in their car, whatever, you have to use POS 02. Getting this tiny detail right directly impacts your reimbursement rates, so don't overlook it. Okay, before you hit submit on that claim and accidentally summon the wrath of an auditor, I want you to run your provider's notes through this ultimate compliance checklist. First, you need explicit documentation of patient consent. Second, you absolutely must list the specific technology used, whether that's Doximity, Epic MyChart, whatever it is. Third, the physical locations of both the provider and the patient have to be in the note to justify your POS. Fourth, those proper modifiers we just talked about must be appended. And finally, your total time or MDM criteria has to be heavily documented to justify the specific code level you chose from the 98,000 to 98016 blocks. Check all those boxes and you are audit-proof. Guys, these new 2026 guidelines really are a massive leap forward in standardizing virtual care. Mastering them right now is going to put you so far ahead of the curve. But as remote care just keeps rapidly evolving, it leaves us with a huge question. Will these strict time thresholds ultimately save our healthcare system millions of dollars, or are they just going to create a frustrating new web of red tape for our providers? Only time will tell. Keep this explainer bookmarked for quick reference the next time you're staring down a tricky telehealth chart. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.